Good evening, everyone. So my name's Ratuja and I'm the founder of Basic Surgery. So tonight we've got Mr. Robert Grounds, who's an ST6 in ENT in the KSS Deanery doing our ENT webinar. Before we start, I just wanted to say a couple of technical things. So if you do have any tech issues, please use the chat function either on Zoom or on YouTube if you're watching via YouTube. And just let us know in the little function down there. And we do have some MCQs tonight, so we are going to share a URL and a QR code for you to participate in them. So make sure that you're ready to have that. So are we ready to start?
Great, yeah.
Great.
So I think you've covered this already and talked about the use of Mentimeter, and we're just going to go through the aims. So thank you very much, Ratuja, it's very kind. I'm Rob Grounds, one of the ENT registrars, and just briefly what we're going to cover today, we're going to try and get a little bit more confidence in how to manage the acute surgical patient, and viewing this as though you were seeing them from the point of view of a GP, an A&E trainee, or somebody who's doing a ward job and just coming across these patients and these type of conditions. I wanted to kind of focus these things on things that we see commonly. We've done talks before where we've covered the life-threatening conditions, but they don't actually come up very often. So I wanted to kind of make a mix of both. And so we've got common conditions tonight, but also just having a think about what we might do in some life-threatening situations, when you might want to refer, what initial management is appropriate to take, and so forth. So as we said, if we go through to the Mentimeter to start, so if you scan in that QR code, that should take you through to a pre-lecture MCQ, and I'll give everyone a minute or two just to get all of that across. Perhaps, Ratuja, if you could give me a thumbs up once you think it's about the right length of time. Great. So the first question, and something really common, relates to a 3-month-old who's brought into you while you're working in your GP practice, and they've got a temperature. And when you initially look at them at 3 months, it can be difficult actually to get an idea of what's going on, but you can't see anything obvious. So being the diligent GP you are, you have a look in their ear, and this is what you see. You see this red bulging tympanic membrane. At this point, what would be the correct thing to do? Should you just reassure them, give them some Calpol and send them home? Perhaps reassure them, give them some Calpol and some amoxicillin and send them home? Or if you're really concerned, you're going to send them into A&E for ENT to rule out mastoiditis. So I'll give you 10 seconds more just to have a think. Right. I hope that's not too patronising for those who deal with this regularly. We'll go through a bit more detail afterwards. So question 2, this time still with ear pain. This time it's a 23-year-old who pitches up to A&E while you're working there. They'd seen their GP last week, who's given them some amoxicillin, and despite taking that for 5 days now, they're not getting any better. It's significantly tender all around the ear. You might try to have a look in the ear, and it's just really poorly tolerated. Putting the otoscope in causes agony. So what would you do at this point? You sort of change tack and give some topical drops, change tack and give some different antibiotics. Perhaps it's resistant to amoxicillin, or again, you're going to admit via A&E with a referral to ENT to rule out something more nasty. Yeah, I'll just give you another 10 seconds, just have a think. Great. So almost there, halfway through. Question 3. He's got a classic elderly gentleman who's warfarinized for AF, and he's had nosebleed on and off for a few hours at the GP practice. He's pitched up at 9 a.m. because it's been bleeding, and you do the sensible thing. You know, calm him down a little bit, sit him quietly, squeezing his nose, put an ice pack on, and when you finally come back to see him again, it seems to have actually stopped. What would you do in this situation? So, gently with a stopped nosebleed, got a few options in front of you. You can either give him some Naseptin cream, something that's used commonly. Again, we can go through the details later on. You could think about medications and warfarin and antihypertensives, or despite it stopping, you could ring ENT emergency clinic, ask them if they'll try and cauterize his nose. Again, I'll give the guys about 10 seconds, have a think and see where you think the right answer lies in this one. Great. And finally, you're a foundation doctor working on your geriatrics ward, a patient who's confused, has had a fall and ends up with a CT scan. And I think we've seen that very commonly. And then a little bit surprisingly, on the report, it comes back saying that they've got otomastoiditis, but no obvious intracranial abnormalities and no bleed on the brain. So what do you do at this point? Otomastoiditis sounds alarming. You're going to give some antibiotics. Is it relevant to look in the ear and try and examine? Or would you just kind of pass go and contact ENT for some advice at this point? Great. So good. Hopefully we'll go back and visit those and make sure we're all 100% on the end. But while we're there, we'll go through to case 1 and just talk through in a bit more detail. So I've changed this one slightly just to make us think a little bit, but case 1 this time is the same patient, but they're a 4-year-old this time. You're seeing them in peds A&E, and they're a patient who kind of has that classic cluster of symptoms: hearing loss, ear fullness, some pain. Often in younger children, it's very subtle. It's changing behavior and tugging on the ear. Putting poor Ratuja through this, but I have a 1-year-old at the moment who's had an ear infection last week, and it's sort of crying a little bit, waking up at night, notice that they've got a temperature, pulling on one ear all the time, and it can be quite tricky actually to kind of to get it right. So I think it does raise the importance of always having a look in the ears if you can, when you're in that GP practice or when you're in A&E and you've got that temperature of unknown origin. Looking in the ears in kids can be quite tough. Actually, you can find it difficult to get a good view. Sometimes there's a bit of wax, but usually with a bit of manipulation, you eventually get a view. And this is what we're after. I don't know if people feel that they want to on the comment section type in what they think is going on here, just to get your kind of thoughts percolating. But when I look at this ear, anyone kind of have any feeling about, would they be worried if they saw this eardrum? Any comments coming up, Ratuja? Nothing yet. It's tricky actually on Zoom to kind of get this right. So
we've got some comments saying not worried. Not
worried. Yes, spot on. So good. People are on the ball. This is a beautiful, healthy eardrum. We've got malleus coming up. I mean, one slight thing that always comes up in exams is this a left or a right eardrum? If you imagine that the eyes are up here, then this will point to the side where the eyes are. So this must be a left eardrum. We've got malleus pinging up here, connecting up to incus. You can actually see that coming down, and I think this will be incus coming down and stapes down here, and the nice stapedius tendon. We've got a light reflex, which is slightly overemphasized in textbooks because its absence isn't particularly exciting, but when it's there, it's nice and reassuring that you've got a nice shape to the eardrum. And you can see that it's translucent. You can see through and pick up details behind. You can see the promontory skipping along behind there. So it's a really nice, nice looking eardrum. Anyone want to, via the comment section, again, just muster any guesses that jump out, or know what this one would make you think about? Sorry, I haven't unmuted you, Ratuja.
Sorry, can you hear me now?
Yeah.
We have some people saying otitis media.
Yeah.
Otitis media with effusion.
Yeah, and that's a spot on. So actually, this is otitis media with effusion. You can see, and we'll get to the next bit in a second, you can see the bubbles behind this eardrum, suggesting that there is fluid behind here. We've lost that nice pearly translucence. And this is actually glue ear, or otitis media with effusion. It's sterile fluid behind the eardrum. What going back, what can be quite interesting is obviously in these patients with glue ear, it's not an infective I think at the time when you're looking at it, but they can get hearing loss. They can find that their ear is a bit full, and it can even be a little bit sore, and it's managed quite differently from that acute otitis media patient that we saw in earlier on in our GP practice. So we've got otitis media with effusion there. And then before we move on to otitis media, here we've got another ear examination, this time getting a really poor view of the drum. Again, anyone in the comments section want to think what you might be seeing here?
We have a lot of people saying otitis externa.
Yeah, spot on. So you're all on the ball. Exactly. You know, this narrowed ear canal with debris floating its way through, and we'll talk a little bit about that and the differences in management in a second. And last but not least, I'm sure I'm not going to kind of patronize you guys anymore, but here, this is a classic for otitis media, or acute otitis media. I think one of the things I took me a little while to get is actually yes, it's red, and people always comment on the redness. Actually, the single most predictive factor in acute otitis media is this bulging. So you can see that, you know, when we looked at our nice normal eardrum, it's concave. We can go into that eardrum and it's not pushing out towards us. When we look at the acute otitis media, there's pus forming behind this eardrum, and that is pushing this eardrum outwards laterally and giving this bulging picture to it. And that's one of the things we would always pick up in an acute or in a glue ear, you know, otitis media with effusion, with the sterile effusion. It's not under pressure in there. It's not pus forming organisms. So this is still not bulging out towards you. And sometimes it can be a little bit tricky to tell the difference between the two. But where you've got this eardrum bulging out towards you, redness, then you're settled on your diagnosis of acute otitis media. Obviously, this child, or this person, and this ear connected to this person, someone who's got, you know, a temperature because they're systemically unwell, so they often tachycardic, tachypneic, and febrile, and this is a systemic illness. That, of course, should be differentiated from this, which is a very mild cellulitis affecting a tiny portion of the skin in the ear canal, and they tend not to have any systemic features. So they'd be very rare for an otitis externa to have a temperature. It'd be very rare for them to be tachycardic, or very rare for them to be tachypneic, because of what's going on. So we get this quite different picture in terms of how they are systemically. Because this is a systemic illness, then the treatments are systemic. So the kind of classic history we're seeing with this patient is they're getting pain, and they're getting their hearing loss because they've now got pus filling up the middle ear, blocking off any vibrations that are hitting that eardrum, stopping that malleus from vibrating nicely and transmitting sound. And they'll tend to have, as we talked about, the systemic features of temperature, tachycardia, tachypnea, so forth. Perhaps if we think about it from an evolutionary perspective, as that pressure builds up within the middle ear, there's a tendency for the tympanic membrane eventually to rupture, release all of that pus, and you get frank, purulent discharge coming out of that ear. You're dripping down people's head. You sometimes see it. I think just going back to where we were here, something to contrast with the otitis externa picture. When you ask the patients, you say, oh, is there discharge from the ear, both in otitis externa and in otitis media with a ruptured tympanic membrane? They'll say, oh, yeah, it's discharge. But when you pin them down, these guys will say, yeah, there's a bit of scanty stuff on my pillowcase. Whereas if you've got frank pus that's pouring through a perforated eardrum, you're going to have a look and it'll be on their shirt and on their t-shirt and dribbling down their neck. And that's not necessarily a worrying thing. This has been designed over millennia to be a pressure valve and burst and allow that pus out and save us having to do anything else. In terms of management, there's very clear, nice guidance, as I'm sure all the GP trainees will know. This is the most common infection that we get, particularly in children, and we'd be expecting the average 1-year-old to be getting up to 3 of these a year. So it's really quite common. Management, yes, painkillers. So when we're talking about our 4-year-old kid, it's going to be some Calpol. As long as they're over 3 months old, you can give Nurofen as well. In ENT, we have a tendency to give decongestants, spray up the nose, and the rationale being that you open up the eustachian tube and allow some of that pus to drain out that way. And it makes us feel very clever in ENT, but actually there's no evidence it makes any difference at all. And so I've put that in brackets. You see people do, but doesn't improve outcomes in any way. And then there's the age-old antibiotic question. And actually the nice guidance is fairly clear on this, that as long as you're over 6 months old and not immunocompromised or chemo, so forth, actually there's no real benefit in taking antibiotics for this. It will settle on its own. Even if there's a hole in the eardrum, that will settle in time, perhaps even better, it will heal quicker. And if there's a perforation, then yes, they need to keep that dry. But eventually, what we talk about over a few weeks, that will start to heal. Patients with a perforation sometimes say, oh, what do I do? I say, keep it dry. And at some point, in a month's time, have a visit back to your GP and just get them to have another look with the otoscope. And if it's healed, then there's nothing else that needs doing. If a few months down the line it's still discharging or not starting to heal properly, then we can have a think about that in the ENT clinic. So I think that leads us on to kind of the red flag, so to speak. So, if it's not improving and you've got a question about the diagnosis, then fine, we'd happily have a look in ENT. Someone with persistent discharge that's been going on more than a couple of weeks, again, I think that's reasonable for us to have certainly a chat about over the phone. The obvious red flags, when we think about the path of the facial nerve, it's running down the posterior part of the middle ear, and then exiting out through the stylomastoid foramen. And in a reasonable portion of people, in most of us, it's got a nice bony covering on, but sometimes when we open up that eardrum, you can, surgery, you can see it dehiscent, not covered in bone. And in those people, if they get a really nasty otitis media, you can get a facial nerve palsy. And in those patients, we probably then would think about certainly, antibiotics, think about them systemically. And also what we would typically do if it hasn't already burst, it is just do a quick myringotomy, put a hole in, put a grommet in, drain all of that pus off and at least release the pressure on the nerve, and think about some steroids as well. So certainly if you've got someone with a facial nerve palsy, you should refer them into ENT. Similarly, in terms of acute otitis media, it can spread into the mastoid, it can spread up towards the brain. And when I'm thinking about that, I quite like this picture. Just to kind of get your mind in terms of kind of 3D anatomy about what's nearby. But if you've got an eardrum, yeah, okay, it can spread laterally by bursting the eardrum. That's great, good news. Sometimes you can get a picture where you've got someone who you think, I really think you had the history and febrile. It just really sounded like an otitis media. But when I look in that canal, you've then got that scanty discharge and a bit of red and inflammation. And that can happen. You can have an otitis media where the pus coming out really irritates the canal and leads to a secondary otitis externa. And in those cases, you treat both with some treatment for otitis externa, which is drops, as we'll get onto, and systemic treatment, potentially with some antibiotics if there's uncertainty. Obviously, the middle ear connects via the adductus into the mastoid, a series of air cells, bony air cells, in the posterior part of the behind the ear. And we've get on to that in a little bit more detail. And finally, occasionally, and had a nice case not that long ago, you can see that then spreading from there. So we had what's called a Bezold's abscess, which is where mastoiditis spreads down into the neck. So people present with a neck clump and a history of otitis media, facial paralysis that patient had as well, actually. And you can also get some nasty things like vertigo, which again, in the presence of a discharging ear and vertigo, we'd want to be thinking about having a look about systemic antibiotics. Last but not least, of course, is just above the ear. The brain sits here, and the tegmen that is a thin bony covering on the top of the middle ear, can sometimes be breached. Be very rare, but those patients are going to be drowsy with GCS dropped and other neurological symptoms. So this case, interestingly, continues, and you've sent your patient home, no antibiotics. Mum gave you a bit of a hard time about it, as they always do, but you stuck to your guns. And a week later, you're doing your next A&E night shift, and this pitches up. And I don't think I need to give any prizes for saying that in terms of diagnosis, that you're worried that this could be a mastoiditis at this point. So mastoiditis, we've talked about pus spreading through the antrum, the biggest air cell, into the mastoid, and then breaking down these bony spicules. You then end up with a red swollen lump behind the ear. The back of the ear here, we call this a postauricular sulcus, and you tend to get obliteration of the postauricular sulcus. It's just saying that it's swollen and boggy here, but we like to make ourselves pretend to sound slightly cleverer by saying things like that. And the ear will tend to be pushed forward. So when you look face on with the patient, you've got one ear stuck out and the other ear nice and flat where it should be. I think what's key with this is there are a few other things that can cause something similar. So, we do have lymph nodes sat behind the back of the neck, and you can sometimes get a little lymphadenitis. And when you look, it will be quite similar. There'll be a red tender swelling behind the ear, and the ear might be pushed forward a little bit. What's key is this is from an acute otitis media. So this patient will have all the features of acute otitis media. They will have the systemic features, the temperature, the tachycardia. They'll really be quite sick because they've got acute otitis media, and now they've got osteomyelitis at the bottom of their skull. So they really will be quite sick as a dog. When you look in the ear, they will have a bulging red protruding eardrum that's stuck out at you. If you see a normal eardrum, when you think back to this setup, it'd be very, very odd for them to have a trap pus in here that's brewing, but nothing communicating through into the middle ear. So, really, we would want you to try and have a look at the eardrum and just make sure that you've got the diagnosis right. Completely normal eardrum would make me fairly confident that this is just a little lymph node behind there. In terms of management, so we've got a poor kid here, and we've seen their eardrum, and we'll get on to actually the next bit in a second. So this was actually just related to what I was saying a minute ago, thinking about the connection between the middle ear and the mastoid cells. So here's a CT scan, axial slices just through the middle ear, and we sometimes, for the exam revision, sometimes like to describe this as the ice cream cone. So you can see what looks like a cone here with a little blob of ice cream on top, and that's the malleus, and the incus sitting there. Here you can see the parts of the lateral semicircular canal sat there, and bits of the cochlea in front. And here's the mastoid bone behind. And here's the antrum, the biggest air cell within it, and the various communicating bits of bone, a bit like a sponge sticking out from behind it. And you can see how that communicates with the middle ear. And this is one of our patients who had a CT scan for an unrelated reason. They had an acute otitis media. They were on some antibiotics from their GP, and they got involved in a car crash while someone else was driving. And you can see here really nicely, so this is basically a CT scan of a patient with otitis media for other reasons. You can see the eardrum. If we look on this side, we've got the ear canal, black being air, so black is good in the mastoid, black spaces within the mastoid air cells. Here's the ear canal. Perhaps with an eye of faith, we could maybe comment that that's a tympanic membrane, or perhaps stapes sticking in. It's a bit ambitious. On this side, we can see the middle ear is full of pus. The eardrum is bulging out towards you, and that communicates in with the mastoid air cells being opacified as well. So if you CT this and you're the radiologist, they will report this as mastoiditis, even if the patient doesn't actually have any features clinically of mastoiditis. Sometimes in those radiologists who are excellent and they kind of recognize the difference, they'll use the term otomastoiditis, suggesting that you've got a middle ear full of something and it extends into the mastoid, but whether that is mastoiditis truly or whether it's just some fluid. I mean, the other thing to think, of course, is a glue ear would also give exactly the same picture. So in a child with glue ear, where we said they've got sterile fluid behind the eardrum, you'd expect the mastoid perhaps to be a little bit opacified. Or similarly, in a patient who's been in that trauma and got a bit of a bleed, then again, you might see some fluid from the middle ear extending into the back of the ear. So, you know, just labeling everything as a mastoiditis is a bit of an oversimplification. This, however, have true mastoiditis. And again, I'll open up the comments. There's one thing on this scan that really does worry me a little bit. And perhaps if Ratuja just interrupt if anyone puts some comments down. While we wait for people to think about that, I mean, we can see our ice cream cone again, we can see malleus, and we can see the connection into the mastoid. Looking at the bony spicules that are nice and defined here, similar to the other side. On this side, you can see the breakdown of that bone as this infection is starting to destroy the mastoid bone. So you've got
so we've got some people saying fracture or bleeding.
Yeah, fracture and bleeding. So this could be one of the suture lines. And in fact, there was a fracture in this patient. Certainly it's possible. There's one extra bit that I would draw your attention to as well, which is...
sorry, I've got some actually asking, is it...
Oh, sorry, I've lost you there for a second, Ratuja.
Temporal bone osteomyelitis?
I mean, that is a mastoiditis. So temporal bone osteomyelitis is effectively what that is. One bit that I'm quite concerned about here from an ENT perspective, actually, is that these are little black bubbles, but this is not in the middle ear, this is in the brain. So this patient has got a communication from the mastoid here through the tegmen somehow, with communication of air coming through. So this patient, you know, is in a real pickle actually, because they've got a middle ear full of something, a mastoid full of something that's destroyed all of the bony spicules and eroded through into the brain, and they ended up going off for a joint neurosurgical and ENT intervention, because obviously as you open up the ear, their brain starts to leak through, so it's a bit of a pickle. We're getting in, I don't want to kind of overwhelm with too much detail, but it just sort of bears the point that we do sometimes get these referrals for mastoiditis, and you just have to assess them clinically. You know, mastoiditis is clinical diagnosis at the end of the day. Have a look in the ear and see what you think. And if they're not tachycardic, they're not febrile, and their eardrum looks normal, just have a think what else it could be. We'd happily have a chat on the end of the phone from an ENT perspective, but don't just kind of jump to the conclusion based if the CT scan uses that word. So we are returning. So this could be this patient here. That last CT scan is not actually because that's an adult scan, but you know, we've got this patient who's got all the history going for them, a recent upper respiratory tract infection that led to some discharge from the ear. They've got loss of that post-respiratory esophagus, sick as a dog, and here we go. They're going to need some really hardcore antibiotics. Most trusts I've worked in, we tend to give ceftriaxone that gives cover into the brain as well. Obviously, plenty of painkillers. And we'd admit them, blue light them through to A&E and then into an ENT ward. The management initially, you know, there was a little bit of controversy about what the best thing to do is. There was a lovely meeting last year that I went to where they had three otology professors debating, and some say they'll typically wait 24 hours on IV antibiotics to see what happens. Some say, yeah, that they would always operate immediately. And some say they sort of play it a little bit by ear to excuse an awful pun. Certainly, if we're thinking about operating and the patient stable, we'd be thinking about a CT scan, because that'll tell us where we need to involve the neurosurgeons. But obviously, if they're so unwell that we don't even have time to go through a CT scanner, then sometimes we'll even skip that and operate straight away. Certainly, there was a lady in a trust I've worked in before who was really, really very unwell, and effectively, as she came through the door in A&E, put a grommet in and took her straight through to theatre, and she didn't do very well, unfortunately. So, you know, we do treat this very urgently, and this can affect children or adults, and it is really serious. So that leads us on to I think this is now the kind of third part of this first question. Sorry, the rest are a little bit shorter and we do get to the point a bit quicker. This is often something we see. So, you know, mum said, you've just seen my kid, that's great, they've got acute otitis media, we're going to go home. You are just having a quick look in my ear. Obviously, you do the diligent thing and get them booked in and you have a look, so you can document in the notes and this is what you see. And as I'm sure you've all pointed out already, this is acute otitis externa. It's inflammation and infection in the canal rather than in the middle ear itself. It's a disease of adults, so we don't really see it very often in children, despite the fact that kids obviously do a lot of swimming and have narrow canals. We really don't see it that frequently. They tend to have acute otitis media. It's previously been known by other names such as swimmer's ear, so really common in that age group. And if there is one thing you take away from tonight, one thing at all, is that otitis externa, when you suspect this is treated with ear drops, not with oral antibiotics. The drops should contain some antibiotic in them and a little bit of steroid ideally, but that's not always the case. So we sort of counsel patients to make sure they keep the ear dry. I sometimes use the analogy when I'm trying to explain it to patients that, you know, if you wash your hands 20 times, you tend to get this chapped, dry skin, and eventually it starts to get infected and you get flakiness on the outside. And it's a similar mechanism, we think, with otitis externa, just in a narrower space that can't swell. So you get this dry, dead, flaky skin. It's incredibly painful. We take a swab just to see what we can grow and then start some ear drops. The safest ear drops to use when in this case you can't see through to the eardrum, which is fairly common. So theoretically this patient could have an acute otitis media, as you said, with pus coming out into the canal, giving you this as well. So if you were to use ciprofloxacin, then it's considered safe, even if there's a perforation. It won't do any harm to the clockwork behind the eardrum. That being said, gentamicin, for example, although it is ototoxic, ENT UK have put out a position statement where they said for, you know, cases of otitis externa, even in the presence of a perforation, you are justified in using an ototoxic antibiotic for the shortest possible time, provided you counsel the patient. So, you know, sometimes we get patients who come through and they've had ciprofloxacin, you're convinced this is otitis externa, the swab comes back to say that it's resistant to ciprofloxacin, and certainly in those cases I'll use some Gentazone HC. It's got a little bit less resistance. Ciprofloxacin does have some bacterial plasmids, understand, can make it quite easy to become resistant to it, whereas Gentazone tends not to have that. So, you know, a 10-day course of ear drops is what's needed here. Sometimes we get to the point where this ear canal is so stenosed and so narrowed that you think any drops you put in are just going to flow straight out. And at that point, that's perfectly reasonable to contact the ENT SHO on call. And we typically, Monday to Friday, every day will have some slots specifically for this, actually just hoovering out the ear, suction out all that dead tissue. Again, the logic being, if there's dead skin in there, just being wet and a breeding ground for infection, it gets better quicker. Hoover it all out and give a space for the drops to come in. Sometimes if it's so narrowed and edematous that you can't even get the hoover, and then we'll put a little, what's called a wick in there, which is just a tiny little piece of packing that allows the drops to work their way down and into the right area. So it's something we see very commonly in ENT emergency clinic. Sometimes, you know, if there's just a little bit of redness and it's just a little bit flaky, then I'm sure the GPs amongst you tonight will know about Optimize spray. It's quite a good alternative. It's a little bit less harsh than you know, Gentazone, for example, and the spray action is quite nice. You can get away with it in younger kids as well, and it can just be a good way of kind of treating a mild otitis externa without the need to hoover the ear or put them through Gentazone treatment. So I think it's really important just to differentiate between those sort of cases, you know, otitis externa, adult disease, swimmers, systemically well and treat with ear drops, whereas this acute otitis media is kids, systemically unwell and treated with oral antibiotics. So that then takes us on a bit of change of scenery, and I think we've got a slot for some questions at the end. Just drop those in your mind. So case 2, this is, you're in A&E, you see a young, poor 19-year-old girl who's got this horrible looking tonsils, sore throat both sides, a bit of a temperature mildly as well. They're systemically well enough, and they've got some lymphadenopathy, and they can swallow at the moment. In terms of the diagnosis, I'm not going to patronize people. This looks really nasty, like a tonsillitis, doesn't it? In terms of managing them from an ENT side, actually, the first question I always ask when I'm referred these patients is it sometimes takes people by surprise, but actually I care about whether they can eat and drink, particularly whether they can drink. You might be off your food if you've got a really nasty sore throat, but if you can drink fluid, and I had one of these going on, to be honest, I would want to go home and take some Calpol and take some Brufen and sit it out at home rather than spending time in hospital. If I couldn't drink even a drop of water, however, that would be the kind of deciding factor that unfortunately means you'd probably head in to stay in as an inpatient, so you can have some IV fluids. In terms of kind of describing the terms in the back of the mouth, some people do find it a little bit difficult. We've all looked in the back of the mouth, but often don't think about what's there. But effectively, uvular dangly bit in the middle, tongue on either side, and then the anterior pillar, palatoglossus, sits just in front of that tonsil and covers. So the tonsil actually extends out here and round behind that mucosal covering and that muscular covering. The presence of white patches on is a bit like that light reflex. Some people with a really nasty tonsillitis don't seem to have very much exudate at all. Some people with really quite minimal symptoms, when you look in, you've got pus all over the place. This patient here, again, I'll throw that out there. Anyone want to comment on whether you'd be worried necessarily looking in that mouth? Anything in the comments at Rutuja?
Yep. So we've got people saying yes, they're worried.
Yes, they were. Actually, this is actually a completely normal throat. So you're right, they're very enlarged tonsils. Maybe this person's had scarring and tonsillitis in the past, but actually, if this patient doesn't have any symptoms at all, they've just got big tonsils, I wouldn't do anything more with that. Big tonsils, they've not got any trismus, they're opening their mouth really nice and wide. If they said that they were fine, I would be happy with that. We do sometimes have people who just come through and they just want reassurance they've got symmetrically big tonsils. I think it's slightly different if one tonsil is the size of America and the other tonsil's tiny. Then you need to be thinking about whether or not there could be something nasty lurking underneath there. But sorry, Tuja, can't hear you at the moment. Still muted. Sorry.
Sorry, can you hear me now?
Yeah.
Some people are asking, what about the uvula? Isn't it deviated?
That's a really good point, actually. Yeah. So uvular deviation is one of the things we talk about in quinsy. But actually, there is a little bit of a misnomer that obviously you've got the base of the uvula here, and you've got the tip, and the tip can wobble any way it likes. And in some people, it's stuck up to the side, some people, it's all over the place. But the key is whether the base of the uvula is very roughly in the midline. So, taking an eye of faith, sort of have the incisors coming down to the middle of the tongue there, but the base is where we're looking at. And to me, that looks about okay. But you're quite right. There's often a lot of confusion, but that is the base of that uvula that we talk about when we're thinking about uvular deviation. And an excellent question, because actually that leads us on to, not quite yet, as if this is just another patient with tonsillitis. You get the idea here. Again, there's the tonsils. Here's the mucosa over the top. They've actually got a little bit of redness to the mucosa. So this is what's sometimes referred to as a peritonsillar cellulitis, where you've got inflamed. You've started to get cellulitis of the mucosa overlining it, which is pretty nasty. So they're typically quite unwell at this point and not feeling great. I'm surprised if this patient was eating or drinking. You can see the uvula started to get quite edematous and just not looking very happy either. The question here that always comes up is this a quinsy? Well, the base of the uvula appears central. Both are pretty nasty, but I'd probably say within the realms of a little bit, not particularly one side more than the other. And same goes again here. So even though you've got one tonsil a little bit bigger than the other, the base of the uvula remains about central. You've got good mouth opening. Whereas when we move on to, we've got more to talk about. Sorry, I'm getting ahead of myself. So this patient, we're saying, has just got a tonsillitis. And as I'm sure most of you know, these patients are managed with penicillin in the community, 10-day course, and some painkillers. Nurofen actually being particularly good, so ibuprofen being particularly good for sore throats. People often poo-poo it because you can buy it over the counter, but it's actually slightly better than paracetamol in a few fairly poor studies. The other question, obviously, that just jumps to mind is obviously the choice here about penicillin. We tend to give penicillin in preference over amoxicillin for sore throat because tonsillitis can be caused by viral causes or by bacterial causes. And in the case of viral causes, particularly Epstein-Barr group is present, amoxicillin can give a nasty raised rash. And so we try to avoid amoxicillin. Very occasionally we get that patient who's had a sore throat, had a course of amoxicillin, and then dermatology ring us because they're a bit pissed off that somebody's got a nasty rash all over, sandpaper feel to it, and could we come and treat our tonsillitis? Thank you very much. From our side, this is actually a slide I've taken from our ENT inductions, but I tend to kind of just offer it so that you know where we're going. So if we've got absolute dysphagia, we really can't drink even fluids, then we'll tend to admit them and convert that penicillin into benzyl penicillin. We think about metronidazole, and we send off for Epstein-Barr virus in the form of monospot or LFTs and gives us some IV fluids. There's a lot of question about, can you tell the difference between viral tonsillitis or bacterial tonsillitis, and certainly a lot of people say, oh, exudate means it must be bacterial, no, exudate means it must be viral, and unfortunately there's no one hard and fast rule. A few different groups, Central, the American guys, and fever pain is what we're told about using here, have tried to kind of put this together, and effectively what you're kind of looking at is in patients who have an upper respiratory tract infection, have that chesty cough, who have had all the features of a coryzal illness as well, then you're thinking that might well be a viral thing. Whereas in that patient who's just got an isolated strep throat with inflamed tonsils, severe pain, can't swallow, then that might push you towards thinking this is bacterial. And so, Centaur have their score, and they say if you get more than 3 or 4 on your score, then you're thinking about antibiotics. Fever pain scoring that you may have heard about gives a backup prescription of antibiotics if they 3, and gives antibiotics if they score 4 or 5. What's really interesting is since NICE brought out their guidance, there's been a few, so that NICE have said actually you don't always have to give antibiotics if you've got a low fever pain or central score. And since they've done that, and they've tried to reduce the amount of antibiotics given out, there hasn't seemed to be a massive jump in the number of quinsies or complications we're seeing from this. So, you are able to reassure patients, and if your patient does end up with a quinsy, it's not your fault for not giving antibiotics in the first instance if you've justified your means. I guess all of this actually is a bit interesting from an ENT perspective. We tend not to use it that much, ultimately. The ones who we see in ENT, we do have a tendency to sort of over prescribe them with antibiotics. And so I do feel for the poor GPs who are having to make these sort of calls. If they've come to hospital and they can't swallow, then obviously I'm going to give them antibiotics. So there is a tendency for patients, I've heard feedback saying, oh, well, I went to A&E and they gave me antibiotics there because the ENT guys saw me and I couldn't swallow. And I do feel for the GPs because they maybe saw them 3 or 4 days before that, and they didn't really meet the criteria for antibiotics. And we'll back you up on that, in due course. There's no evidence that not giving antibiotics increases quinsies or delays treatment when you're only giving it to patients who are otherwise okay with just a bit of a sore throat. So here we go. This is part 2 of your case series. Expect this time we've got the patient back, they're unable to eat or drink. We've got an arrow helpfully pointing out what's going on here. This time they're really quite septic, high temperature, right-sided pain only, and I'm not going to patronize you by asking that, but this is certainly the question about whether this could be a quinsy. A bit like with the eardrum that bulges out towards you. Again, here on this side where palatoglossus is, you can see this sort of smooth, concave feel to it. And on this side, you can see this fullness under here, Quinsy is an abscess around the tonsil, not actually in the tonsil itself. So the tonsil is sat there within the mucosa, the tonsil is sat here within the mucosa. This is where the abscess is, in the gap between the side of the tonsil and the deep spaces of the neck. Here, perhaps with an eye of faith, this is taken at a slightly skewy angle, but you perhaps could argue that this base of the uvula is deviated over a little bit. I've got some more pictures of a diagram just to kind of give you a feel for where we are. And in here, they've made it very clear that the base of that uvula is deviated over. And they've got this fullness here with the tonsil pushed across to the midline. Here's another patient here. Again, it's a bit unfair of me because this is someone who unfortunately got a slightly skewy angle of, but again, they've got a big fullness into this space. And the same again, just so we had plenty of pictures, because I know a lot of people find this a difficult concept. The features you're going to get with this, so often we get trismus, and that's because you've got the pterygoid muscle sat here, which can be irritated by the quinsy, the abscess that's forming out here, and so people find it difficult to open that mouth. They've got spasm stopping you from opening the mouth properly. You've got the uvula base of it deviated over away from the midline of the tongue. You often get what we describe as a hot potato voice. So because you've got this up here, you've got this sensation that there's a hot potato in your mouth, that can't speak properly. And then obviously they're sick with it. So obviously these patients we tend to manage by removing some of that pus, and that tends to make people feel a little bit better a bit quicker. This is actually a patient who, again, has had a CT scan, not something we would normally do in the UK, but I just came across it. And it gives you an idea of the anatomy. You can see the airway here, tonsil kind of in this area here, and this abscess, in this area here, and this abscess forming out behind it. And just giving you an idea of where it is. We would tend to do in ENT is drain that with some stab incisions or a little aspiration with a needle. We kind of talk about the idea that the tonsil is not your enemy here. The tonsil, if you put a needle in it, it's not going to do any harm. It just tends to bleed a bit. But actually, we get behind that. So we aim quite high, quite wide, quite lateral, and just put a few little needle aspirations in there to try and remove some of that pus. This is a slide I've taken away just from my ENT SHOs when we're doing induction. But just so you're aware of the steps and kind of what we're thinking. I find that we'd have to get a really good headlight on so we can have that look in. We tend to give some xylocaine spray in most places I've worked. Some people use a little bit of a xylocaine injection, but if you're injecting local anaesthetic, then you might as well just take the pus out with another needle. So we tend to spray away and then aspirate a little bit of pus. In the past, people used to do big stab incisions with a scalpel, and some people still do that. There was a paper that said about aspiration versus incisions with a scalpel, and it wasn't brilliantly conducted, but it didn't show a huge difference between the two groups. So most places we tend to just aspirate with a needle. And then obviously these patients have a nasty tonsillitis that's driven all of this, so we would tend to admit them and admit as per a tonsillitis as well. So, brief mental pause, that takes us on to a different case. So here we are, case 3, Saturday night, kind of classic. I'm sure many of you have come across this situation, seeing someone who's taken that left hook and then they show you a photo on their phone now, and it used to look lovely, and now they can't work for L'Oreal anymore or whatever it is that they do. And there's 2 bits really. I think the first is the urgent check that we often tend to forget, and the second is the bit that actually we can manage less urgently. So anyone want to make any comments about, as well as looking at the shape of his nose, what else would you look for? I'll just give 2 or 3 seconds if anyone wants to comment in there.
So people are asking to check for a septal hematoma.
Perfect, yeah, and that's absolutely right. Missing a septal hematoma is it puts a real medical legal situation there. It tends to damage the septum, and then you end up from in this situation where the bone has been broken, which can be nicely straight and very straightforward. If you've got a septal hematoma, as we'll get to in a second, it can lead to permanent damage of the septum. Is really difficult to fix, and perforations, which are really challenging in theatre. So another picture, a nice nasal fracture. assuming you've ruled out a septal hematoma, then what we'll tend to do is when it first happens, when we see them, it's actually so swollen often, 2 or 3 hours afterwards, it's really difficult to push it straight. And it's obviously so painful, and they've been through quite a lot on those days. So we tend to bring them back to ENT clinic, an emergency clinic, at around 5 or 7 days after the injury, and have a look at that point once the swelling's gone down. And all we're offering them effectively is whether or not they want us to push it straight. I'm afraid there's nothing more than that. 2 big thumbs and push it one way or the other. And sometimes patients say, do I really need to come? I've been hit on the nose. Clearly this chap would benefited from us pushing it straight. But some people say, it's swollen, but it looks straight. No, this is a purely cosmetic thing, and we're going to offer to push it by eye straight. It's not going to be perfect, but we'll do our best. We can do that under general anaesthetic, but actually, we can also do that under local anaesthetic if you've got the right patient group as well. Clearly, for a younger child or someone who's really concerned about their nose, and maybe general anaesthetic might be better. But for that old gent, who's toddled in his suit and tie and just wants it a bit better, then we can push it straight under local anaesthetic. The obvious thing, we've talked about septal hematoma. You guys all got that right. We would want to see that the same day. So even if it's 5 o'clock in the evening, we'd want to see that and potentially take that to theatre to drain it, rather than waiting until the weekend before we have a look. From the nasal trauma point, then obviously we can take that referral and book them in emergency clinic for a week down the line. In terms of septal hematomas, I get a lot of phone calls because people are unsure. They know that it's important, but they don't 100% know what it looks like. So this is one of the nicest pictures I could find on Google of what a septal hematoma looks like. And it's fairly classic in that they tend to be bilateral. If you've got the mucosa off the septum swelling out, often you've got a fracture through the cartilage as well. You tend to get blood shifting into the other side. You can get one-sided septal hematoma, but they tend to be bilateral. And this is fairly classic. It looks like a giant raspberry up their nose, I always think. It's usually fairly obvious when you see it. In terms of the kind of the etiology, we've got cartilage down the middle, mucosa over the top. And if you get a bleed into that gap, it pushes that mucosa out and causes your hematoma there. I think what's important on this slide is remember thinking about the nose. If you chopped off the front of the nose, you've got this pyramidal space across the nose, and coming out from the side, you've got these inferior turbinates, bony structures covered in mucosa that stick out from the side. And we do get a lot of phone calls where that bit is slightly confused. In terms of examining them to try and identify what's going on. And here, in clinic, this person's using a specialized Killian speculum, but actually, to be honest, the easiest way is just to use a normal otoscope. In kids, they're not going to tolerate you putting a speculum up their nose. So I tend to do the kind of classic of, making a piggy nose, oink, oink, shove a little otoscope up there, and you get a really nice magnified view. We've talked about what to expect up the nose, and I think sometimes people get a bit thrown. So this is up their left nostril, like where we're looking with this Killian's, and you can see we've got a septum here. We've got the inferior turbinate coming out from the side, and you've got the middle turbinate up further behind. The septum, ideally it should be straight, but many of us have had trauma over the years, so you can get slight indentations and crests and so forth and little spurs in it. So really, as long as you're not looking for this giant raspberry sticking out front, you're not always going to find a completely dead straight turbinate. Sometimes in the absence of certainty, what I'll do in someone who's got a really deviated septum, but they say, oh yeah, I've had that for years, and just actually taking a little probe, something hard. We used what's called a Jobson horn probe in ENT, but actually I've used cotton bud before because it was all I could find in A&E, and you're just going to gently prod that septum. And a septal hematoma, this feels squidgy. It feels like it's full of blood and wants to be popped, whereas someone with a little deviation of their septum, it will feel firm. It will feel like the normal septum of a hard cartilage. And this is a kind of classic referral that we get. Someone has had a look up, they've seen a red raspberry up the nose, must be a septal hematoma. Do remember that a septal hematoma will come off the septum. You don't get inferior turbinate hematomas. So if that lump is originating from the lateral portion of the nose, then it's probably the inferior turbinates. I would probably say about 50% of referred septal hematomas I see are actually just the inferior turbinate coming in laterally. Yeah, and I don't mind looking, you know, don't want to miss this sort of thing. So if there's an element of doubt, obviously send them in, but just bear that in mind. Great, so we're getting there. Case 4 or 5, epistaxis. Interestingly, a lot of epistaxis, I'm not sure how to do the plural of that, you know, with traumatic bleeds, we tend not to see a huge amount of epistaxis from that because it's often fit young people who have been involved in trauma. It tends to settle. Epistaxis, unfortunately, the kind of group that we see is present in this little vignette. So we've got this 78-year-old presenting to A&E, left-sided epistaxis. Often they've had these herald bleeds of on and off for a few days before, and it's been bleeding for 10 minutes despite doing all sorts of things. You find people doing the weirdest things to stop their nosebleeds. You know, you often see people with bits of toilet paper sticking out of their nose. There's this old wives' tale that tipping your head back is the right thing to do for epistaxis. It's really quite unhelpful. What that does is it tends to cause the bleeding to dribble down along the hard palate into the back of your throat, so you can't breathe. That's not brilliant at all. So the advice now is obviously to settle forward a little bit. In terms of sucking things up the nose, they tend to be very drying. So tissue paper up the nose dries out that mucosa. Often this is a cycle where you've had, you know, on and off bleeds. The dry mucosa then gets chapped, bleeds more, you start a cycle. So you try to discourage them from doing that. You know, you've got this classic picture of this elderly patient, and this, when they bleed from the nose, it can seem absolutely horrendous. Even a few tiny, I'm sure you've all done it, cut your hand or whatever it is, or had a nosebleed, dribbled into a sink full of blood, and a few drops into that sink of blood, and it looks absolutely full to brim. And so we do tend to hear, you know, torrential bleed, lost litres of blood, and actually when you do their HBs repeated, it seems to come back normal. It's really, really common. And obviously a lot of these patients have comorbidities. Occasionally people, you know, you do get the odd death from epistaxis each year, but it's really, really very, very rare. A recap of the anatomy, I'm sure you all remember this from anatomy med school. Why does it tend to bleed and where does it tend to bleed from? It's predominantly from one tiny area called Little's area at the front of the nose, as is highlighted here. And it's because you've got this plexus of anterior, posterior, ethmoids, phenopalatine artery, greater palatine and superior labial all meet at this one point and overlap, and you get a really rich plexus, and that's almost always where it's bleeding from. You know, occasionally it's from different places, but I'd probably say over 90% from that spot. We do referrals for kids with epistaxis, and I guess as we've seen in COVID, where kids seem to be less badly affected, and we're all very reassured by that, exactly the same is true in epistaxis. It seems to be very self-limiting with children, that often it's triggered by a bit of digital trauma, and actually by the time we get to them in A&E, it's almost always settled on its own. A lot of kids do get epistaxis and tend to grow out of it as well, which is quite nice. In adults, you know, we tend to see often this anterior bleed. Yes, you can have elderly patients with comorbidities, you know, the obvious ones being hypertensive or on aspirin or warfarin or some of the new NOACs, and they're the ones who really we want to see. This is actually a slide, again, I've taken from our ENT induction for our SHOs, but I think it's sometimes important just to kind of see the management as a ladder where we kind of work our way through. And effectively, for 90% of patients, you're going to be giving them direct pressure. I tell them to sit with their head forward, an ice pack on the back of the neck, an ice pack on the forehead, and squeeze their nose, the soft part of their nose, for full 20 minutes. There's no evidence for the ice pack at all. I just quite like the idea of giving patients something that they can do themselves at home. And, you know, you get a bag of peas out and it just makes things feel better. The data is very poor, but the rationale is that if you cold things make blood vessels vasoconstrict, so if you reduce that, then maybe it would make the nosebleed a bit smaller. If you've got an anterior bleed from Little's area, which is almost certainly what we have in most cases, then cautery is perfectly reasonable, and many GPs are doing this now, which is brilliant. We encourage that. Obviously in A&E, some A&E staff are trying to do the same, and it's a nice little skill. If you've ever done an ENT job, it's really good to get your hands around. headlight on, have a look up the nose. And if there's an obvious point that's bleeding, then a simple local anaesthetic on cotton wool and some silver nitrate applied to it really does the trick. It causes a bit of scarring. That the silver nitrate releases nitric acid. That the acid then burns the tissue, a chemical burn, and that causes scar tissue to form, and the scar tissue doesn't bleed. And over many years, it will remodel itself. But it's really nice for stopping these little bleeds. In A&E, what we're finding is that a lot of the time we're getting to the point where rapid rhinos, they've been around only about 10 or 20 years, so certainly all the time I've been working, which is nice. And from what the elderly consultants tell me is it's completely sort of changed the game. They are just so effective. You put a rapid rhino in, sometimes you need to put one in on the other side to apply counter pressure, and sometimes you inflate them with a bit more air. And the only thing to think about is that if you do pack a patient's nose in A&E, you are really committing them to an overnight stay, because we have some data that's suggesting that these work well if you leave them in for about 24 hours. But if you take them out much sooner than 18 to 24 hours, there's a really high chance of rebleed. Warfarin actually, if the patient's warfarin, if you've got a patient who's on warfarin at a low level, perhaps they've got it for AF, then I often ask them to hold it after a discussion about risk benefits. If you've got someone who's got a valve and can't reverse it, we'll often leave them with their warfarin running, as long as it's not super therapeutic. So we do often carry on with that. If their INR obviously has gone up to 12 and that's what's triggered this, then obviously we'll try and control that a little bit. From an ENT perspective, we tend to get involved. If we've not controlled things with rapid rhino, obviously these patients are going to come under our care on the ward, but there's not, I'm afraid, very much for us to do. They're packed in A&E, and we just babysit them and remove the packs the next day. Our other options are sometimes, we will use some other chemicals, something called Flow Seal. It's kind of a cement that goes up the nose, and very, very rarely, if we're having recurrent bleeds, the in vogue operation at the moment is what's called a sphenopalatine artery ligation. So we go up the nose using cameras and we get into the maxillary sinus, and the SPA, it runs nicely along the back wall of the maxillary sinus, so we can tie it off in its various branches or cauterize it, and that just reduces bleeds going forward. So from the A&E perspective, what you're going to do, so sit them up, sit them forward, stop them leaning back, get them to squeeze the nose. I always tell them that when you're squeezing that nose, your arm will go numb long before your 20 minutes of squeezing or 30 minutes of squeezing is up. So they need to be sat on the corner of something with their arm rested on the corner of the bench, or over the toilet bowl, over the sink, wherever it is that they're dripping onto, and squeeze this off part of the nose. Obviously, if at that point things haven't improved, then we're going towards the admission point of view. So we're looking at OBS, IV access, make sure their INR is okay, give them resuscitation if it's a significant bleed, although that's actually quite rare to need, and address any comorbidities. From what to do at that point, so let's say you've reassessed and it's actually stopped bleeding. There's a cream called Naceptin cream. It's made with peanut oil and some antibiotics. Just be careful, because people with peanut allergy can't take it. But there's some evidence that suggests actually using it doesn't cure, it doesn't stop you from having it, but it reduces your chance of having a rebleed slightly. So it's always worth trying. A lot of patients, again, poo-poo it. They've had another nosebleed after they use Naceptin, but I keep giving them back to it in clinic. It doesn't cure things, but it just reduces their chance of having another one, makes it less likely that they need to be seen again. Obviously, we've talked about the idea of cautery if you're trained to do it. If not, obviously ENT on site usually are able. In some places, on Good Word in Manchester, that they're actually using bipolar electrocautery in A&E, which is obviously a step forward under a local anaesthetic, just to get those epistaxis sent home. And then obviously rapid rhino put in as the thing that kind of buys us time about what to do next. We've talked about warfarin already, and hypertension and management of those comorbidities. So I think I've gone on to. In the past, before rapid rhinos, they were posterior packing. Being completely honest with you, I've only ever done this once in 5 years as an ENT registrar, because the rapid rhinos are so effective And this was what one of the, I think it was almost a barrier, because it's quite hard work to try and get this in. You're trying to layer layers of ribbon into the nose. And to be honest, I made it bleed so much by packing that I don't think I'm ever going to try it again. Instead, actually, if you've got rapid rhinos in it, it's very, very rare to see it bleeding around those. And other packs that you sometimes see, a Merocell, a soft absorbable one, but it's probably just not as good as the air inflating rapid. I don't have shares or anything in this, by the way. They're just something that we use an awful lot. And so for that, I just wanted to go through very briefly about how it is that we use them. We sometimes see them misapplied, which is understandable if you're not doing them regularly. But if ENT are busy, or you're at a hospital where you don't have ENT, or you're out, with a catastrophic bleed far away in a community, and then they really can be a lifesaver. So pick the most bleeding side first. You've got your rapid rhino here. It comes wrapped up like that. It's got this blue packaging on the outside of the rapid rhino in the sealed thing. Do take that off, and they're hard to remove once the balloon is inflated inside the nose, which we've had to do a few times. And then we dunk them in a little bit of water. Then once you plop them up inside the nose, they're exactly like an NG tube. You want to be going parallel with the hard palate. There's a tendency you see sometimes that they're going in at an angle up towards the brain. Don't want that. More parallel with the hard palate. Insert them all the way in. I always get a patient sat so that they have their head resting against a chair. So move the chair next to the wall, because otherwise, as you try and push the thing in, they just keep moving further and further back, which can be really difficult. And unfortunately, these are one of these things that you have to be cruel to be kind, because just putting them in is agony. I've had a go actually, practiced myself, and it really is very, very sore. So you be confident, be slow, but be firm, and get them in all the way to the hilt, and definitely give them some analgesia as soon as you've got them, ideally beforehand, but it's not always possible. And then you inflate them with air, not with water, as we sometimes see. Very occasionally, despite putting that in, it's still bleeding. And what I tend to suggest at that point is just putting one in the other side to apply counter pressure, because that cartilage can be a bit wobbly. And also, sometimes you put them in, you inflate them with air, and then that pack just shifts slightly, builds its way up underneath the turbinate, and you just need to apply a bit more air to really pack things out. So it's something that now A&E are getting really good at doing, and it just means that patients can get kind of expedited care, which is really good. Lady who's got packs dangling out. So we don't want this. We don't want the rapid rhinos. These aren't actually rapid rhinos, it's a Merocell, but they're dangling out the nostril. And remember, we talked about how it's Little's area. So we really want them right in, so they're pressing on Little's area, so right up to the hilt rather than half dangling out. Okay, last case. So making our way very slowly, but almost there. We didn't include this one as one of the MCQs because, I think it's one of those things where it's very rare to have a situation where there's only one action that's important here. In this case, you've got a sick child who's in tripod position, giving you that implication that they've got impending airway problems. They're drooling, which suggests something's really, really wrong. People don't drool unless they're very, very sick, in my experience. And so this is going to be something that you're going to be managing as an MDT. If you're a GP in the community, you're going to be getting help and getting them across to A&E very quickly. And if you're, in A&E, you're going to be getting the senior matron and all sorts of things. What's quite common is often we're referred these who have come in, triage are very good, and they often say things like, "Oh, I've looked in the mouth, everything looks normal." And if you've got a drooling person with a normal oral examination, to me that's basically epiglottitis until proven otherwise. So I'm sure you've all heard of it. I'm not going to patronise again with asking you to comment, but that's what we're worried about in this sort of scenario. So epiglottis, it catches a few people by surprise. Again, you're beginning to see the trend here. The first picture after the case is a normal eardrum, a normal throat, and here's the normal epiglottis just peering up, sort of waving at us there and doing its thing. A little cartilaginous protective cover that sits over the top of the airway and flops down. Here's another normal epiglottis just taken with a little endoscope through the mouth, so you get a bit more of a view, and you can imagine the vocal cords are sat behind here. Clearly, if this gets swollen, it will impact on this airway, and that's why we get really antsy about it. Here we've got a view through a nase endoscope of a really nasty epiglottis, and you can see that, sorry, this is actually taken from a different position, which is a little bit harsh of me, but normally with an endoscope dangling from the nose, you would expect to see the vocal cords coming up here, and here the epiglottis is swollen, and if it gets much bigger, it will get in the way of that airway, and we get a bit of a problem. So, as I'm sure most of you already know, epiglottis, in children, it's a real life-threatening thing. Adults, we do see it as well. The causative organism is Haemophilus influenza, Hib, and it's part of our vaccination schedule, but we do see it's sort of a bimodal peak with this, where we have young kids who haven't completed vaccinations are more likely to get it, and then actually, that old gent again who had his vaccinations many years ago, or maybe even was there before the vaccinations existed, although they'd be very old by this point, and now they've started to wear off, and they can often get this situation as well. So we do see it in adults. Obviously, they're very sick, they're very unwell, they're tachycardic, and when we start to see SATs and heart rate go in the wrong directions, then we start to get very, very worried indeed. And obviously, it's very sore, tend to get plummy voice and drooling out, spitting out that saliva. In terms of management, when they come through A&E, it's really about getting as many different people around as possible. I tend to allocate, if we've got a young kid with it, someone who's a good communicator to actually speak to the parents, because they get very anxious and the kids get very anxious. So you want the parents there. We're managing this with A, B, C, D, E. So getting that airway assessed, getting oxygen, getting SATs on, then you're going to move on and get your heart rate, assess the rest of them, make sure you're not missing anything else. We use adrenaline nebulizers, and the idea is if you can put a little bit of adrenaline on, it causes vasoconstriction and can just shrink this down, and that can be given repeatedly until you get everything else under control. One is nice and easy way to remember it. It's 1 mil of 1 in 1,000 adrenaline, and then just plonk that on plonk it into the nebulizer cup in A&E, the normal one that you'd use when you've got an asthmatic coming through, and then fill it up to the top with 4 mils of normal saline, and that's your thing. So anyone can make that up. We've put about Heliox here, it's in the textbooks. To be honest, I've never even seen it used. The idea is with Purcell's law, that when you've got a less dense gas, then you can travel the gas through that tight space easier. But to be honest, by the time we find the bottle, most of the time the patient's already secured. Steroids are useful as well, and we always give them 6.6 of dexamethasone. I'm sure the medics amongst you will ask about hydrocortisone as well, and I've been reliably informed by an endocrinologist that probably there's not a huge amount of difference. So I think it's just a cultural thing that we tend to give dex in ENT, but any steroid that's fast acting is appropriate. And in terms of antibiotics, again, most places it's ceftriaxone as a very high dose stat. Perhaps one of the things that comes up is, yes, ENT, we want to be involved in these cases, but actually the clue here leads on to our next slide a little bit. From an ENT perspective, people assume that the treatment in a compromised airway will always be an emergency trachea, and that's fine. That's what we're there to do. But actually, the best treatment here, and I'm sure most of you will have worked out what this is an ET tube. This is a patient with epiglottitis who's gone to theatre. We've been scrubbed and ready on standby to do a tracheostomy, and the anaesthetist has very competently put an ET tube through and secured the airway that way, and that's much better. It avoids the scarring and everything else, and also the sweaty backs that we all get from doing this tracheostomy. So that's great. The very last thing I want to talk, and we're really nearly done at this point actually, is just talking about the idea of tracheostomies. Obviously, we're there to do them, but we're not present in every hospital, and it's something that I think everyone should be aware of. Certainly, the old school teaching was that you did a big slash down the middle of the neck and put a tube in, and that's sort of gone by the wayside. There's a lot of bleeding and a lot of complications for it. And I've deliberately put in the wrong picture here. So this is actually a cricothyroidotomy, which is what is now advocated as the best way forward. But they've got a little jet into the facial area, like a mini track in there. And anaesthetists who are very good at doing their audits, they they have a society, DAS, Difficult Airway Society, and they had a look at use of mini-TRETs and deaths in cricothyroidotomy, and they found that there was a lot of problems associated with people using airways that they're not familiar with and doing things that they're not familiar with. So their guidance now is you feel in the gap, you've got thyroid cartilage, cricoid cartilage, feel the gap in between, you put a sharp thing in, push a bougie through and put an endotracheal tube through, and that's what they're advising people do in extremis. Our hope is that no one would ever have to do this. Certainly from my side, I've never done it, and we would want to be doing this if we had to be doing it in theatre rather than in A&E. And then in theatre, we're quite comfortable. We do this sort of thing all the time. It's quite a lot of experience, so we're really happy. Just kind of thinking about that, you know, if you were out in sticks or doing your mountain expedition medicine, etc., would you be happy to do that? You could save a life. So staying away from all of that, let's get back to our MCQs again. I'll give a second just for people to get the code and things loaded up. I'll ask Rutuja to give me a thumbs up once she's happy. Thumbs up. So let's go back to MCQ1. So you've got your 3-month-old child, and they're brought in to see you. What is the correct management in this case? Thumbs up. So in this one, it is giving them some antibiotics just because they're under 6 months old and they're a bit at higher risk. If they were over 6 months and there's otherwise nothing to see except otoscopy, then you could just reassure Calpol discharge. Certainly, if there's nothing to see, you wouldn't be thinking about mastoiditis. Question 2 then, so I'll leave a second just for people to answer through. Great. So yeah, as you got this, this is an adult, so you're thinking otitis externa already. They've had a week of oral antibiotics, which didn't help. Well, of course, otitis externa is not treated with oral antibiotics. They've often, actually, one thing we didn't talk about is the tragus, the bit on the very front of the ear, is often really, really tender in otitis externa. So that could be a little giveaway. And then when you try and put the otoscope in, they just jump off the couch. Maybe you get a glimpse of that nice picture we saw with the crustiness in the ear canal. Sometimes you get very poor view at all. But in this case, I would start some ciprofloxacin at this point and then see them back to properly examine it once it's settled down. It can be quite slow, so I do reassure them that it often takes 7 days for things to settle. And the pain can often seem out of proportion. Without wanting to be sexist, we've had ladies who have given birth and tell me that otitis externa is more painful than that. So it really is very, very, very sore. And changing to clarithromycin, okay, fine. Maybe you've got a resistant bug and an otitis media, but that wouldn't be my first point of call. And again, if there's not a huge amount and you've got this anterior tenderness, then I'd be thinking about otitis externa. One thing to think about is in mastoiditis, in otitis externa, you can get a little bit of tenderness around the ear, and sometimes we'll refer those patients who've got ear pain and it's just a bit tender when I touch their ear. But again, if you've got features of mastoiditis, you're going to have that bulging red drum, temperature, systemically unwell. So that's what I'd be thinking. Great. So almost done. This was the elderly gentleman. What to do at this point? Great. So this was really, really unfair of me, and I'll ask Rutuja to give some feedback in a second. But actually, all of them are perfectly reasonable. I think, if it's stopped bleeding, you could say, well, it's stopped bleeding. You haven't yet treated anything. Let's give them some Naseptin. And actually, in many cases, you'll never see them again. They just had a nasty bleed, and that's it. It might be worthwhile having a look at their, medication, antihypertensives, to make sure the blood pressure is well controlled. That's associated with epistaxis. And there's some evidence about apixaban being slightly safer in terms of less bleeds for epistaxis than warfarin. We sometimes advise in recurrent bleeding where we're really struggling. We just ask GPs politely to consider switching across to one of the newer NOACs, for example. So it's something worth trying. Certainly, it's easier to control if patients are also struggling with getting that INR within range for various other reasons. And then finally, the idea of cautery. Well, if you look up the nose and you can see an obvious bleeding point, then it's certainly not unreasonable to ask us to have a look and cauterize. I would probably say that in most cases it's not needed, that if it's stopped on its own, you give some naseptium, you control the other comorbidities, you don't need to do anything else. But if you've got experience and you either want to cauterize yourself or you look up the nose and there's an obvious point where this keeps coming from, then that's reasonable for us to have a look in either an emergency clinic or as an outpatient clinic. Final question then. So this was our Jerry's ward, a common kind of referral that we get. Someone with osteomastoiditis reported on the CT scan. What would you do? Nice and quick. Thumbs up. So I hope everyone's put that we'd examine the ear, and obviously that's exactly it. We want to have a look. Does this correlate clinically? You've got a clinical diagnosis. Ignore the radiology. If they've a bulging red ear and they're unwell, absolutely give us a ring and get those antibiotics started. But actually, the first step is just have a look in that ear and see what it looks like. Great. So we've talked about some really common ENT conditions. I've tried to pick things I think that we see really commonly and things that we discussed with really commonly. We've talked about some life-threatening things as well, epiglottitis, and when we want to be involved. And give lead time there for any questions. Anyone want to discuss anything further?
Thanks, Rob. That was really great. We do have one question, and that's asking, is there any evidence that early antibiotic treatment for otitis media could reduce the risk of mastoiditis?
So there's been a few studies. Most of them have been really badly conducted. So most of them we sort of discount. There was some data from Hess where they look at the incidence of mastoiditis, and I saw a lovely slide with introduction of advice not to give antibiotics and the mastoiditis rate, and it has not really changed significantly. So if I use that broadly speaking, the answer is no. So we would back people up if they said we chose not to give antibiotics. The data out there suggesting that will, if you wouldn't have got mastoiditis is not convincing.
Great. And I think we've got time for just one more question as we're running a little bit over. And it's asking, do adults ever get glue ear?
Yes, they do. So absolutely right. It's more commonly children. Adults can get it. If we see one-sided glue ear, we do like to see them as a routine referral in ENT clinic, because sometimes, if your station tube is blocked, perhaps by a polyp, perhaps rarely by a tumor, then that can lead to a negative pressure in the middle ear and an effusion forming. So yes, adults can get it. Adults commonly get it after an upper respiratory tract infection, usually bilaterally. But if it's one-sided, we would definitely want to see them in clinic. If it's bilateral, hasn't resolved after 3 months, we would definitely see them in clinic as well.
Actually, I've got one more question just because it's quite interesting, if that's okay. So there is someone who currently works in ED and they're asking, what is the best way to manage tonsillectomy rebleed?
Oh, yeah. So it's really nasty. And every year we have a handful of tonsillectomy bleeding deaths. And what can be quite distressing about it is obviously it's usually performed on well children as an elective thing, and they don't have that reserve. Again, it's A, B, C, D, E, and get loads of people involved. So, we want to know in ENT, anaesthetics will want to be involved because they're going to basically be asked to put us to sleep to go back to theatre if it's bleeding a child with a bleeding airway, which is kind of absolute nightmare for them. They want to be involved early, and we really get help from A&E and paediatrics in terms of about getting lines in and replacing blood as fast as it's bleeding out the top of their mouth. A bit like the epistaxis in terms of positioning, we sit them forward so they're spitting out into a bowl. We sometimes try things from an ENT perspective, like putting bits of adrenaline on the top to kind of stem any bleeding, and not a huge amount of data for that. If it's a significant bleed, they're going to go back to theatre, and we're just going to have to basically cauterize the area that's bleeding. If it's a very minimal bleed, then we will tend to keep them for 24 hours in hospital and just observe them. But basically, if you get one through A&E, don't send them home. Bring us, okay, fine, you can start a little bit and just keep an eye on things. And if it's actively bleeding, then get a lot of people very quickly, and we'll talk about to theatre.
Great, thank you, Rob. Should we go on to the next slide now?
Sure. So, oh, great, yeah. So actually, Rutuja, do you want to say about this instead? Just thank you very much indeed. And
yeah, so thank you. That was actually like a really useful talk, Rob. It was really appreciated. And we've already got like quite good amount of feedback. So it would be great if you could complete the post-course questionnaire. That's going to pop up on your screen when you finish the webinar. And for those of you watching on YouTube, the link is in the description provided. And for that, you'll get your certificate of participation, and they have been a little bit late to be rolled out to everyone, but they are coming very soon, I promise. And yeah, it's a really useful way of like sort of telling us what we're doing right and what we can improve on. And on the next slide, we have our next speaker. And Rob, do you want to just quickly go on to the last slide for me, if that's okay? Thank you. So, oh, now we've finished the slideshow.
I think that's it. Okay.
Could you go back? Yeah, there we go. So our next webinar, which is going to be next Wednesday at 7:30 p.m, is going to be on trauma, and that is by Professor Manzoor Khan. And he's fantastic. So we've got the QR code on the screen that we can leave for you for about 30 seconds if you do want to sign up. And once again, thank you for coming, and thank you so much, Rob. That was like super interesting and really, really useful.
Thank you very much for having me. Cheers.
Right. So I think it's now time to end the webinar. Thank you.